Morning, everyone. I am Vansh Devani. I'm currently serving as the National Public Health Officer at Pujata Ishwaroju, and we are very delighted to welcome all of you for the Zoom and YouTube live stream. For those joining us for the first time, the Medical Students Association of India is the country's largest youth-led organization of future healthcare professionals, affiliated globally with ISMSA. Within MSAI, the Standing Committee of Public Health is dedicated to bridging healthcare dividing by empowering medical students to lead evidence based public health advocacy, grassroots education, and community outreach across India. Now, you might be asking yourself, why this webinar and why now? The number tells a stark story. In India, roughly 16,000 to 18,000 transplants are performed annually, yet over 3 lakh patients remain on an active waiting list. While the global average organ donation rate stands at 11 or 12 donors per million population, India's rate is just 0.81 per million. Every single day, approximately 20 individuals lose their lives simply waiting for a match. The tragic shortfall is not merely just clinical. It stems from gaps in public awareness, structural bottlenecks, and deep seated social hesitation. By bridging the knowledge gap and active championing organ donation, today's webinar aims to build a well-informed medical community and public ready to advocate for life-saving organ donation and transplantation. I would also like to ask all of you to fill the pre-event forms to be eligible for the certification. And with that, I'd like to pass on the floor to Sunana. Thank you.
Thank you, Vansh. Good afternoon, everyone. Good evening, rather. I'm Sunaina Singh, CEO of Organ India, and it's a pleasure to welcome you all to this important seminar, Introduction to Organ Donation, organized by Organ India in collaboration with MSAI. Our deepest gratitude to the MSAI team, as well as to all our guest speakers who have taken out time from their very busy schedule to come here. Today, we're gathering here to discuss how healthcare professionals like yourself can play a crucial role in advancing organ donation and transplant. So, our first speaker today is Dr. Anil Kumar. He's director of the National Organ and Tissue Transplant Organization, or NOTO, and additional deputy director general under the Ministry of Health and Family Welfare, Government of India. Dr. Kumar has played a very important role in strengthening India's organ transplant framework. As head of the National Organ Transplant Program and nodal officer for the Transplant Rules 2014, he has been closely involved in the development and implementation of systems and policy relating to organ donation and transplant. His extensive experience also includes work in transplant registries, coordination, and patient safety, and he has served in several important national roles, including ex-director of National Blood Transfusion Council and chair of the committee that drafted the Biomedical Waste Management Rules 2016. Through his leadership at NOTO and his contribution to strengthening systems, policies, and coordination in organ donation and transplant, Dr. Anil Kumar continues to play an important and dynamic role in this field in India. He's right now traveling, but he has made sure that he's found a corner where he can talk to all of you today. We are delighted to have him here. Dr. Anil Kumar, thank you for joining us. And your topic is organ donation and transplant, the Indian model.
Good evening, everyone, and thanks to Organ India and Sunaina particularly for giving me this opportunity to address you all, the young future doctors of the country. And I'm really delighted to be amongst you, addressing you regarding this organ donation and transplant Indian model. And I'm also happy to see some of my esteemed colleagues who will be addressing you. So Shriram will be shuffling the slides. So Shriram, go to the next slide. So as you know, organ donation and transplantation in a country is not a new thing. It has been known traditionally. We know Maharshi Dadichi, who donated his bones to for the for forming a weapon which was called Vajra to kill a demon. And then we have also example from the mythology of a xenotransplantation when the Lord Ganesha was transplanted with elephant head. Next, please. Our Honorable Prime Minister has also been, highlighting the importance of the organ donation in his Mann Ki Baat addresses. and wherein he has specifically emphasized that one organ donor can save up to 8 lives. Next, please. So, what are various, organ failure, and these are the serious illnesses, really serious. Kidney failure, liver failure, very life-threatening illnesses. And the best treatment in most of these cases is the timely transplantation. And organ transplant is the operation, the surgical operation where this failed organ is replaced by a functional organ. And then where from this functional organ will come? It will come either from a deceased person after death or from a living donor. And as you may be aware that living donor can only donate, usually can only donate one kidney of his or a part of the liver, one lobe of the liver they can donate. And basically, so this it becomes a gift. So gift has to be given to this person who is needing the organ for transplant and who is suffering from this end stage organ disease. And then this gift has to be given either from a deceased donor or from a living donor. Next, please. So we know in our country there are various common causes. In the kidney we have diabetes and the hypertension, which are the commonest one, but there are others also like obstruction, chronic glomerulonephritis. Then liver we have viral infections like hepatitis B, C. Alcohol is another, and then we have non-alcoholic also. Non-alcoholic fatty liver disease, as you may be aware, that it has become an epidemic. Roughly 30 to 40% of the population is now having fat in their liver, and which is causing the accumulation of these fat and then leading to cirrhosis at one time. Then liver cancers are also cause of liver failure, and heart failure mainly caused by cardiomyopathy, the muscle disease of the heart, which many times the ischemic heart disease is also the underlying cause for the heart failure. Pancreas failure is also, again, alcohol is a big culprit in the pancreatitis, leading to pancreas failure. Next, please. India currently, if you look at the absolute number, we are at the number 3 position after USA and China in total number of transplantations that are happening in India. This is 2024 comparison. 25, our numbers are 20,138. Go next, Shira. Yeah. So this is the estimated need. Kidney we require roughly 2 lakh new patients are added every year to the already waiting list of patients. Liver also now estimated to be more than 50,000 every year and 50,000 heart transplant. This is the patients who are there in the national waiting list, which is maintained by the NOTO. You can see the numbers of patients who are waiting. Maximum is for kidney, followed by liver, and around 2,000, around 1,900 for heart, and 1,100. And this is the number that we did last year, 20,138. You can see organ-wise details also. And out of these total transplants, 3,526 transplants were performed with the organs which were donated by the deceased donors. So go next, please. We have been improving over the years. You can see the graph that they are over the years. During the COVID time, only it was down. Go next. Disease donor number, now we have crossed 1,200 donations all over the country, but you can understand with a country of 1.4, more than 1.4 billion people, this is a very minuscule number, that is 1,235 donations that have been recorded in 2025. Next, please. Number of disease donor transplant, I already told you, 3,526 last year, and it has also been increasing over the years. Next, please. These are the states which are, leading in deceased donor transplantation. The topmost is the Tamil Nadu, followed by Telangana. This is the absolute number of disease donations which have happened, and these are the only states where the disease donation happened last year. You can see the numbers, and there are many states where there has not been any disease donation so far. Next, please. So if you look at the total transplantation, the Delhi NCR region, tops the total number of transplantation. But here, around 97% is from the living donor, only 3% is from the deceased donation. So otherwise, the total transplantation, if we look at the number, the Delhi NCR is the highest in the country, followed by Tamil Nadu and then. So, but mainly living donor transplant. Overall, if you look, 18% are from the deceased donor transplantation, and 82% are still happening from the living donor transplantation. Next, please. So, as you may be aware of, that donation usually will happen in a ICU, organ donation, and in a intensive care unit when a patient is identified as a brainstem dead person by the staff who is working over there, which could be a resident doctor in anesthesia or a ICU critical care expert or a neurosurgeon, anybody who is working over there. Or usually the residents are working or a critical care nurse is working. So they will suspect that somebody is a brainstem dead. And then they will, call the whole committee. And then if it is identified to be a brainstem death, first testing, then you can put them on a maintenance mode, because usually if the first test is positive, it is most of the time the second test would also come positive. So brain death diagnosis is done, and then you approach the family with that this is the opportunity for donation. When the person is brain dead, but the heart is going to stop after some time. So that window period between the person who is brain dead and the heart which is going to stop is the time when is the opportunity for donation. And this person, like, who has died, who has been diagnosed brain dead, that person is dead, legally dead, and he cannot be. It is a totally irreversible situation. Dr. Mohanka would be telling you about the law, and then it is a totally irreversible situation. The person, if the family understands the situation that the person is brain dead, and we are maintaining the donor in the ICU in the hope that the family agrees for organ donation. If the family doesn't agree, it is their right. They are well within their right, and they can take a decision. But we have to explain to them, give them an opportunity, give them to their right, that it is their right to consider donation, and we have to inform them that information is to be given. And then if the family agrees, then the information is passed to the SOTO, the state organ and tissue transplant organization, which is now there in every state, which is active in transplantation. So, and then the SOTO will start identifying the recipients who can receive those donated organs within that hospital, then within that state, and then it goes like that. So next, please. So you can realize that there are two types of donors mainly: living donors and deceased donor. And living donor, as I told you, one kidney they can donate and one portion of the liver, usually one lobe of the liver. And living donor has to be of 18 years and above. So 18 years should be completed. And living donors are again of near relative donors or other than near relative donor or a swab donor. So near relative donors among the living category are the 6 categories of near relations which are allowed as a near relative donor, which will not be so much scrutinized, and the hospital can approve them on their own. These are the children, parents, siblings, or spouse or grandparents, grandchildren. So these 6 relations are the near relations, and the hospital, if they have the identity proofs and the identification documents, relationship documents, they can move ahead on their own without the approval of a authorization committee, which will be required in other than near relative case or a swap donor case. Swap is, I'll tell you later on, there is a slide on swap. And deceased donor is a person, like, there is no age restriction. Any age can donate as a deceased donor. Usually, even 1 week child or even a person of age 90 plus can even donate if the organs are healthy. and organs are transplantable. So after natural death, also the donation is possible, but only of the tissues. Like somebody dies at home, we can consider donation of cornea, skin at home, and that too within first 6 hours usually. So the call for this donation should go to the hospital uh, at the earliest, so that within 6 hours we are able to harvest the organs. But after brainstem death situation, we can donate both organs as well as tissues. So next, please. So these are the 6 organs which are commonly used for transplantation. All are, life-saving organs. A person cannot survive without any one of them. So that's why we called, like two of them are paired. You can see kidney and lungs are paired. So if they are given separate to two patients, and if liver is up, can sometimes be split and given to two patients, so we can save lives of up to 8 to 9, patients who are suffering from organ failure of these organs. So one donor can save so many lives. And besides this, Shriram, next, yeah. So we have, many types of tissues can also be donated, provided the hospital needs them and they have the facilities. So cornea, heart valve, skin, bone, and many other tissues can also be donated. So, and these may not be but life-saving, but they will also be transforming the lives. And skin is definitely life-saving because it is used in case of a burn patient, and if we have seen many burn patients whose lives could be saved by the skin transplantation. Next. So this is the swap. If we have a donor available in the family within these 6 relations, which I told you are the near relations, and they are not compatible biologically, so they can exchange donor between those two families or those two pair of donor and recipient, and then this transplantation can also take place. So that is allowed legally. So that is called exchange of organs, just to overcome the incompatibility because of these factors. Next, please. So organs, they have to. Sometimes we are confused that organs can be banked. Organs will not be banked. Organs can only be preserved temporarily in some preservative solution or in an organ box, but they have to be transplanted immediately after retrieval, as early as possible after the retrieval. And these are the maximum time limits for transplantation of the organs. You can see heart is, only 4 to 6 hours is there after the retrieval, within which it has to be transplanted. So the time is the essence in this successful organ transportation. And many times you must have heard we create green corridors at various, and transport these organs through the flights or through air ambulance or through chartered flights also many times to save time. Because they have to be transplanted within a time frame. Otherwise, these organs will become non-functional and cannot be utilized. So that is also very important to understand that organs, they are not banked. They can only be, preserved in a box for a temporary short period. And that these are the limits. Next, please. So what is the structure we have? As per the law, to have this networking, why this networking is required? This is required to have an efficient system of organ, procurement from the donors to their distribution to the waiting patients. So this is required. That's why this, because it's a big country, and so that's why we have state level organization, regional, and all these three organizations, they connect with transplant centers. That is the centers which are performing transplants, retrieval centers which do not perform transplant but can do retrieval, and then banks, tissue banks. Tissues can be banked, not the organs. So we have like cornea. Cornea can be stored in an eye bank for up to 2 weeks, usually in the medium which is available in India. And skin and the bones can be stored even up to 3 to 5 years. So tissues can be banked, but not the organs. So this network is there and which is currently connected to around more than 1,000 transplant and retrieval centers. So all these are part of single network. Next, please. So whenever who will register the patient who requires transplant? Registration is done by the treating hospital. Suppose the Apollo hospital is treating the patient, so they have their login ID password. They will register them in their waiting list, and after registration, the name will appear in the hospital-wise waiting list or in the Delhi waiting list, and then the North region waiting list. So now we have made this waiting list also. It will be visible to the patients who are in the waiting list at what is their number. So, and when the donation is happening, the information I told you earlier also that the information has to happen, go to the particular SOTO, and SOTO will look at the waiting list within that donor hospital also. It has to be done as per the waiting list. And donor hospital can keep all organs provided they have the facility. Otherwise, if it is a retrieval center only, all organs will be shared. Every other hospital also, they have to share at least one kidney. So then first within the state, they have to look for the recipient, and if not utilized within a state, it goes to the region where it is the allocation is done by the concerned regional organization. We have 5 regions in the country and 5 rotos are there. And if region is also not able to utilize the organ, which happens usually in case of heart and lungs, then they will come to the NOTO for allocation. Next, please. So these are this network is currently covering, 5 regions and 31 states and union territory. Next, please. Next. NOTO at the apex level, is responsible for policies, guidelines, SOPs, networking, establishing this networking and the national registry. We have recently also launched a new registry. National level awareness, coordination, and allocation at the national level. And currently, we are also looking after Delhi and NCR and trainings, organ pledging, data bank, and research also. Wherever the research is to be undertaken, the NOTO is to be involved. Next, please. So these are the main issues and challenges you can see, but main issues are, we have high burden of the patients who are suffering from organ failure. Then we have mainly hospital-based issues are the main crux, where it is the less identification of brainstem death, which are the best, donor. Currently, we can look at, and world over also, but we are also having now donation after circulated. I'll be talking about, but that is the main challenge at the hospital level. That less brainstem death identification and certification, and sustainable programs are not there. Many times, after doing 1 or 2 transplant, the hospitals will go into lethargy. They will not feel motivated to continue, and mainly the infrastructure is available in private sector. The government level infrastructure also needs to be improved. Next, please. So why we need deceased donation? As we can realize that living donation alone cannot fulfill the requirement. And while a deceased donor can save up to 8 lives, 8 to 9 lives, but a living donor can only save 1 life, and that too only in case of kidney and liver. And we have, potential disease donor availables, which are mainly, disease donors will come from the trauma ICUs. We have roughly 1.73 lakh deaths in the country, even reported by the Ministry of Road Transport and Highway in their report 2023. 7 lakh stroke deaths. Then we have brain hypoxia patients, which can also be like hanging patients or even strangulation. Their organs can also be harvested. Benign brain tumors also, they are also potential. So we'll mainly get our donors from these ICUs where these patients are getting treated. Next, please. We also run a program which is called National Organ Transplant Program, under which we give grant to for establishing of SOTO, ROTO, as well as for new infrastructure, retrieval center, transplant center, tissue banks. Go next, please. Next. Also for hiring of transplant coordinators for immunosuppressant therapy to below poverty line patient, for paying respect to the deceased donor for their dignified funeral, and for maintenance of deceased donor also, awareness, etc. Also awareness and capacity building also. These are the grants given to the states as well as to some government institutions. Go next. We also have other schemes like Pradhan Mantri Jan Arogya Yojana, which supports kidney transplantation, Rashtriya Arogya Nidhi, which supports all other types of transplantation. Then we have Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana, under which generic medicines, quality generic medicines. Then we have National Dialysis Program at district level and National Relief Fund, which also supports transplantation. Next, please. So mainly as a medical student, you must understand what we need to do to set up a organ donation program in a hospital. Go next. So first of all, the hospital should identify a doctor as a nodal person, and every ICU should have a transplant coordinator identified for to look after that ICU, and their name should be displayed outside. They should have a certified brainstem death board which is certified by the authority, and these members of the board should also be trained. Next, please. As you might be knowing that we have a Glasgow coma scale, which is the easiest scale to assess the coma level. And many times we see that even if the Glasgow coma score is 3, which is no response to every these 3 basic parameters, still these patients are lying in the ICUs and nobody is checking them. Next, please. So we should have a protocol where these patients are, if there is no reversible cause, then we should have, mobilize the brain death committee to identify these donors and the potential donor and get them checked. So we should have these protocols of the BSD should be pasted in the duty rooms of doctors, in the nurses, and these detailed protocols should be available so that everybody have a look at these protocols regularly. Next, please. And they should also monitor their ICUs, that how many deaths had happened in their ICU, particularly on the ventilators, and after the deaths on the ventilator, how many they could identify as brainstem death, and out of these brainstem death identified, how many could be converted to donors. These are the benchmarks which are indicated over there. But even we are not able to achieve 1% of this even in trauma ICU. So that is really a sad situation in the hospitals. Next, please. Next, please. We should be monitoring our brainstem death cases. Next. We also ask the hospitals to put up such boards outside the ICU because legally it is required to request for organ donation. So that which indicates that the doctor or transplant coordinator, they are required by law to request for donation. And so that request has to be, the family has to be informed, and it is ultimately the family's own right and their be informed and take decision. They have to be informed that they have this opportunity of person, even his organs being surviving through many bodies. Next, please. We should have an alert system in the hospital. Like whenever a alert is, released from the ICU by the doctor, it should go to the organ donation team. They should send the brainstem death committee for certification, and the brainstem death committee should go and automatically check. If the first apnea is positive, the alert should go to the concerned SOTO that there is a potential donor, so that the SOTO can start simultaneously identifying. And then family has to be counseled. The transplant coordinator has an important role. And all the new residents, they should be regularly trained, and all the deaths, including brain death, including deaths happening in the ward, they should be notified to this organ donation team. So because in the wards also, you can at least, motivate them for cornea donation. Next, please. So this is just information that now we are also working on promoting donation after circulatory death, for which there have been guidelines issued from the Honorable Supreme Court, like constituting primary board and secondary board, through which we can, certify the, withdrawal of life support, or withholding of life support, and in case of futility of care situation. So in those cases, in a controlled way, we can also have certain cases where we can, have successful donation after circulatory death. So next. Yeah. So DCD, and then withdrawal of life support also. And to promote donation after circulatory death, we also have many technologies also, like machine perfusion and normothermic regional perfusion, which is used to re-establish the circulation. This is just information. It is developing. These things are developing, and a few donation after circulatory deaths have been happening in the country, but the number is very small. We have to increase the number. Next, please. Next. Yeah. So Noto issues advisories to state, has released many guidelines, many new guidelines like brainstem death and swab guidelines have been released on the 16th Organ Donation Day. Also, next, please. You can have a look at these guidelines on the website. So this is the go next. So we are promoting multi-organ donation. We also have a registry for hand transplant, which is functional, and we are also number one in the hand transplant in the world. So that is also, it's a complex tissue, or it is a multi. Go next, Shina. We have currently 9 centers in the country which are performing hand transplants. Next, please. Next. Yeah. Next. So we have a organ transport SOPs which have been released from the Noto side to smoothen the transport. You must have heard, like we have now nodal officers at every airport to smoothen the transport. We have frequent creation of green corridors with the cooperation of police, etc. And we are also having Noto ID for each donor recipient now through the national registry. Go next. Yeah, go quickly. We have also now started registry for cornea and tissue donation and transplantation. Go next. That is functional in the new registry. So basically, regarding awareness, we have to focus on common myths which are still prevailing in the society. As the medical student, you can play a very important role, because these are the common myths. You can read them out at, like for the disease donation, I may be born without that organ in my next birth. My religion doesn't allow, my culture doesn't allow. A donation may disfigure the body, but as a well-aware society, we can dispel these myths. Then we also have myths associated with living donation. You can read this, and that may not be able to work or fall ill or will not be able to marry. So these are also myths. Go next. Even all religions, they promote donation. I'm not going into these quotes of various religions. You can all have a look at them. Because even Islam or Quran or Guru Granth Sahib or the Bhagavad Gita, they all promote acts of humanities and saving lives or helping others. So go next. So basically, we have to then we also are promoting pledging for organ donation. Why we are promoting pledging for organ donation? That currently, when you are alive or kicking and conscious, you can decide for yourself. And these are simple steps, and this kind of a e-donor card is generated. You can scan this QR code. You will be able to access the website. Go next. Uh, Shriram, you can play just this one small video. 5 simple steps are there. You have to go to this website. Even through the main website of Noto, you can access this. You have to enter your Aadhaar number and download the certificate. After filling the form, it gets open. So it's a very simple procedure. It's not much difficult. You have to enter the Aadhaar number and then now it will go directly.
We will
Yeah.
be sharing the
Next, please. Yeah. Shriram. Now, currently, we have like within last 3 years, more than 5.7 lakh. But we all will request you to inform your family members because it's not an individual decision. Basically, ultimately, this your pledge will be
Thank you
filled.
so much
Just
for your
1 minute,
time.
1 minute, 1 minute only. Okay. I'm just winding up. Go next. Yeah. 1 minute. So currently we are running this Jug Jug Jiyog Abhiyan, which is again that the legacy of the donor will continue. Next, please. Next, please. So this is the new website. We have a 24/7 call center that you can see the number. I'll request you to go to the website. So you must why burn or bury when we have the option to donate and save lives. So that is the message that we would like to convey. That donate organs, save lives. So that's all. Yeah, from my side. Thank you so much.
So much, Dr. Anil Kumar, for taking out time and standing somewhere in the airport and giving this talk. Really, really appreciate it. Thank you.
Thank you.
Okay, so let's move on to our next speaker. He's already been here for some time. It's a pleasure to introduce Dr. Ravi Mohanka. He's mentor and director of the Liver Transplant Program, Peripheral Centers and New Projects at Sir H.N. Reliance Foundation Hospital. With over 20 years of experience in the field, his expertise spans adult and pediatric liver transplantation, as well as liver and bile duct tumors. An experienced teacher and mentor, Dr. Mohanka has trained more than 50 transplant surgeons and helped establish liver transplant programs at several government hospitals. He's also an active researcher with over 80 publications and book chapters to his credit and has been invited to speak at more than 400 national and international meetings. He is the past president of the Liver Transplant Society of India, president of Liver Committee of SOTO and ROTO, and president-elect of the Indian Society of Organ Transplantation. He is also a TEDx speaker on organ donation and transplant. His work interests extend beyond transplantation to promoting organ donation, improving access and affordability of transplants, and addressing important ethical aspects of organ donation and transplants. We're delighted to have Dr. Mohanka work with us today. He has worked with us extensively and he has been a real mentor to our team. Thank you, Dr. Mohanka, for joining us. Your topic is organ donation and transplant law, acts and rules.
Is my screen visible?
You just need to make it full screen.
Yeah.
Is it okay with everybody?
Yes,
Nitya?
ma'am.
Yeah.
Okay. So the topic for today is the Transplant Act and the rules accompanying the act. So before this act was passed by the parliament in 1994, there was transplants happening in India, and because there was no central rule, it was basically governed by local statewide rules for each state. Now, it always happens that technology precedes the legal system. So the ability to do transplants was available from 1954 when the world's first kidney transplant was done. And unfortunately, many countries woke up and started making laws for it around 1980s to 1990s, including us. So, between this period, there was nothing illegal. If you did a transplant, it was just like doing any other operation and it wasn't illegal. Unfortunately, there is a big divide between the rich and the poor, especially in country like ours. And people, especially like agents would go to a village and give money to everybody and ask them to donate one kidney. And this is one of the pictures that was published in a newspaper at that time. And it gave us a lot of bad press internationally because it is unethical to sell your organs. So therefore, we needed a law, and we started the process in 1990, 89 or 90, and then we got the law in 1994. Now, this problem was unique not just to India. There are several countries such as Korea and Japan where we didn't really have a transplant law until like 1990, late mid 1990s. So some of the Western countries such as the US and UK and Canada and Australia, they made their transplant related laws a little earlier in the 80s. So we started in the process in 1990 approximately, and it takes about 3 to 4 years to get a law passed, so formulated, get public opinion, and get it passed through the parliament, which happened in 1994. And then to implement the law, you need rules. That those were published in 1995, which 1 year later, which had all the forms that you're going to use to actually implement the provisions of the law. Soon we realized that basically we were behind already because the science had progressed, and there were a lot of gaps in the original law. And in 2011, it was amended with the newer changes, which we are going to talk about, and the rules were published in the very next year. So the main provision of the Transplant Act is that it recognizes brain death as death. Now, uh, typically, most people and doctors think of death when they have a flat ECG or have no pulse or no cardiac activity on auscultation. So, therefore, this was a new concept for doctors, and it had to be put out in a law, otherwise, they won't be comfortable certifying somebody as dead if the law didn't support them. So basically, the procedure for certifying somebody as brain death was laid down very well in this law. And basically, it requires the consent of a disease donation. Either it can be done by the person who is diseased before they die. So, what is called as a donor card, which Dr. Anil Kumar spoke about. So, what one can do is we can sign up to be an organ donor or pledge to be an organ donor after we die. That's called as a donor card. That has to be done with in presence of two witnesses. Although this is not a legal document, but it helps in making a decision by the family later. And after somebody's death, the brain death can or the organ donation can be consented for by any person in lawful possession of the body. Now, this is a question that I saw on the chat box. So, who is a lawful person? Who is the person or next of kin? It's defined differently in different religious acts in India, but generally, for a married person, it's going to be the spouse. For a minor, it's going to be the parents. But for others, it differs from different religions, and it could be the spouse, or it could be the parents, or it could be the brothers or sisters. And for unclaimed bodies, the consent for donation can be given by either the hospital in charge, or if it happens in a prison, then the prison in charge, but only after having spent at least 48 hours trying to identify the next of kin of the body. This is what a donor card looks like, and one can sign up for it. Again, it's very prevalent in most parts of the world. And it should go on a document which you normally carry, which is the driver's license. Um, this is by default, everybody has to make a choice when you make a driver's license in the US, Canada, Australia, and some other countries. But in India, it has been implemented in a few states such as Rajasthan and Maharashtra. So what is brain death? So basically, as we know, there is a part of brain which is the cortex, and there is part of the brain that is brainstem. Now, while cortex does a lot of higher level functions, the brainstem essentially allows you to be conscious, aware of what's going on, and control your breathing and circulation. So if there is permanent damage to the brain stem, then there is no way that the person can be alive, but they can be kept stable or for some time on ventilators and other artificial measures. So the best way to check for function of brain death or damage to brainstem is to look for brainstem reflexes. If they are absent, then you can do what is called as apnea test. Apnea test allows you to increase, sort of disconnect or stop the ventilator for a short period of time. And if the carbon dioxide levels, blood based on your ABG or blood gas, increases by a certain value, it is the strongest stimulant for the respiratory drive. So if there is no spontaneous respiration despite the carbon dioxide PCO2 on the ABG being more than 60, then this is certainly permanent damage to the brainstem, and you can certify them as death. Before we do that, we have to exclude things that can simulate it, such as hypothermia or any drug toxicity and stuff like that. To be extra cautious, our law requires that it has to be done by 4 doctors. The certification has to be done by 4 doctors and twice, 6 hours apart. This is and the doctors have to be part of what is called as a brain death medical board, which is a team of doctors from within the hospital. As far as the living donor transplants are concerned, which Dr. Anil Kumar spoke about, we can have liver or kidney donation from living donors. They have to be majors, they cannot be minors more than 18 years of age. And there's a group called as near relatives, which is defined, which is spouse plus blood relatives. So if anybody of this group wants to donate, then they are called as near relatives. The procedure for getting permission is very simple. If it's somebody who's not a near relative but still a relative, then the procedure is longer, but it is they can also be donors. Now, there are three, the law laid out a regulatory framework for implementation of the act, and there are 3 main bodies. One is called as appropriate authority, and this body is generally the deputy health secretary of the state. And this body gives permissions to hospitals to conduct a transplant, and they can also take away the license if any irregularity is found. The second is authorization committee. This committee is generally, there is one committee in each hospital, and there is one committee in each state. And this committee will look at every single case of living donor transplant, make sure that they are related to each other, the donor and the recipient, and clear their cases. And for cases that are non-near relatives, they will also have to go through the state authorization committee. And then there is the medical board we spoke about that certifies brain death. So what are the requirements? The transplant center should have adequate facilities, equipment, manpower, qualified people. The process is defined in the law, where the authorization committee proceedings, which is for the living donor transplant, they are video recorded, the records are kept for 10 years, and the cost of the transplant has to be displayed on the hospital's website. There is a new entity that was defined in the 2011 amendment, which was the non-transplant organ recovery center. So there are a lot of centers which or a lot of hospitals which have a ICU and a OT, but they may not have transplant facilities. Now, such hospitals are called as non-transplant organ recovery centers, where organ recovery can be done, but organ transplant cannot be done. The minimum requirement for that is that there should be 25 beds, an ICU and an OT. The National Organ Transplant program was also mandated by the law, where they said that the national body, which is currently called as NOTO, has to have an advisory committee. They have to have a network which they have created as outlined by Dr. Anil Kumar as a NOTO at the national level, ROTO at the regional level, and SOTO at the state level. And they have to also maintain registries for donors and recipients, which they do. Now, in case of any irregularity, if there is removal of organs without authority, there can be a jail time of 10 years and fine up to 5 lakhs. If there is a removal of organs without authority by a RMP, then the first time they can be deregistered for 2 years. Second time they can be permanently deregistered. If there is commercial dealing in organs or falsification of documents, they can be 5 to 10 years of jail time or fine of 5 to 20 lakhs. And any other violation of the act, if not within the purview of the first three, they can be jail time of 5 years and fine of about 5 lakhs. So what has the law achieved? So before the law was passed, also there were some kidney transplants like we discussed. But after the law, the activity really took off. And in 1994, the first successful heart transplant was done at AIIMS. 1995, the first attempt at liver transplant was made at a few hospitals. The first success was achieved in 1998, and the first lung transplant in 2002, and in simultaneous pancreas and kidney transplant in 2003 at AIIMS. Now, obviously, it has worked. So over years, the number of organ donations have increased, and the last year was about 1,200 donations. So for a population of 1.4 billion, only after we reach 1,400 donations, then we will reach a figure of what is called as 1 donation per million population. But there are countries which typically have 30 to 50 donations per million population. So although we are a large population, we have a large potential to increase the organ donation in our country. As far as transplants, again, as Dr. Anil Kumar said, last year we did 20,000 overall transplants, but that's very few compared to what we actually need. So the number of the transplant activity is also staggered around the country. So a lot of kidney transplant is in the south and Maharashtra and a lot of northeast states, and in Delhi, but a lot of northeast states and Jammu and Kashmir don't have a lot of kidney transplants happening. Similar is the picture for liver transplants. As far as heart transplant is concerned, it is entirely in the south and west of India, including lung transplants, which are also in the south and lung of India, and very few in the east or north India. Now, to know how many transplants you need, we always assess it based on, or how many donations you need, you always assess it based on per million population. And here the dark blue is where countries which have high donation per million population, and light blue is India, where we are around a little less than 1. So there is a huge potential, almost 40 times, that we can increase organ donation in our country. So far, what we have achieved is we have achieved registration of hospitals for transplants. So there is no transplants happening in hospitals that are not registered with the government. There are regulatory and enforcement agencies are doing a good job. They're monitoring it. The organ trading that was there before the act came into being has been curbed to a large extent, although maybe once in 5 years you'll hear about some scam in the newspapers. This is a recent paper in Lancet last month, actually, and this modeled the current and the future need of transplants, and it is estimated that currently we need about 1.25 lakh kidney transplants, 1.8 liver transplants, 83,000 hearts, and 11,000 lungs. And by 2040, this will increase further. And currently, we actually meet only about 7% of our kidney transplant needs, 1.5% of liver transplant needs, 0.2% of heart, and 1.2% of lung transplant needs. So there is a huge gap that we still need to fill. What could we do more? So the government has actually initiated the process of amending the act again, because significant progress has happened in transplant over the last 10 years. So some of the things that we could do is we could make brain dead declaration and reporting mandatory, which is currently optional, and therefore very few hospitals do it. We could expand the definition of relatives. So instead of calling them near relatives and just blood relatives, you could call them relatives. So it could include your cousins and first and second degree relatives. It will also help more swap transplants, because currently it's limited to only near relatives. There should be more training in BRAINNet certification and donor maintenance for doctors. There's organ procurement, and in post-mortem cases, the medical legal cases is always tough because the post-mortem has to be done after the procurement, and some of the findings could be lost in the process. So to facilitate that, post-mortem could be done while the procurement is being done in medical legal cases. The Noto maintains the donor, the pledge, and the recipient registry, but we have more registries that can be maintained. And there has to be uniform definition of death. So brain death is defined only in the Transplant Act, and not in the IPC, which is now called as BNS, and in Registration of Births and Deaths Act. So we are the only country in the world which has three definitions of death. We have to have common definition of death, and with that it will help a long way to also do what is called as donation after circulatory death, what Anil Kumar spoke about. And once we promote donation after circulatory death, we could easily increase the number of organ donations in our country by about 10 times. And currently the law does not allow any organs donated for research, which should be amended and which should be part of it. So, like I was saying, the donation after circulatory death is making organ donation more feasible in a lot of countries. Some countries have up to 50 to 70% of their donations by DCD pathway, and we don't have we have very few in India. This is something that we should pursue. Thank you very much. Happy to take any questions.
Thank you so much, sir. If there are any questions, you can raise your hands or put them in the chat box. We will receive it from there.
I see a few questions. Should I answer them?
Yes, please.
Okay, so can new technologies such as artificial organs, xenotransplant, and stem cell technology reduce dependence on living donor? Yes. So of course, that's the goal. The goal of artificial organs and xenotransplant is to actually reduce dependence on all transplants, not just living donor transplants. But then we are not close to it being reality, except for pancreas. So for pancreas, we have closed loop insulin pumps now, which are also called as artificial pancreas. And they have actually reduced the number of pancreas transplants being done worldwide in the last 5 years. So other than that, other technologies are still in the making, and my guess is that we are looking at least 10 years before they become reality. They've all made great progress. For example, there are xenotransplants which have lasted like 7 months now, kidneys. But for it to be clinically useful, it is going to still take time. Can the donor select the recipient on his own? For a living donor, of course, the donor and the recipient, they know each other and they decide who the recipient is going to be. But for disease donation, the donor cannot decide, or the family cannot decide who the recipient is going to be. There is a waiting list that is maintained by Roto, and it is given to the next patient on the waiting list. In some cases where living donor itself is providing the consent, but the immediate family is going against the decision of donor, how to handle the situation, what should word it? So in India, the final decision is made by the family member. This is called as opt-in consent. And in addition to opt-in consent, there are safeguards. So the family has the final say. There are several countries where there is opt-out consent, where the person can, everybody in the population is considered to be a donor unless you have opted out. But in that situation also, most countries have what is called a soft opt-out, where the family has the final decision. But there are only 2 countries in the world where it's called as hard opt-out. So everybody in the family, everybody in the country is deemed to be an organ donor unless they have stated that they do not want to donate. And family has no say in changing that decision. Yeah, so that's all the questions answered. Anything else? I'm happy to answer.
Thank you so much. Thank you so much, Dr. Monka. There's
Yeah, so there's a xenotransplant question again, very good question. So of course, when you're doing transferring an organ, transplanting from another species, the risk of rejection will be higher because the antigen profile is even more disparate compared to going from within the species. So, but then now what we have is the CRISPR-Cas9 technology, which allows you to edit genes. And currently, there are like 5 companies that do that. And if you knock out about 9 genes which are non-human and add 3 genes which are human genes, so a total of 12 genes, if you do that, then the what is the organ actually quite what is called as humanized. So these pigs have to be reared with these genetic modifications, and every organ in their body is going to be like what is called as humanized, you know.
Okay. Thank you so much for joining us and taking out your time. Our next speaker is Dr. Sandeep Vesh, who will speak on identification and certification of brain death. It's a pleasure to introduce Dr. Vesh. He's a renowned neurosurgeon with over 22 years of experience. He's currently HOD and Executive Director of Neurosurgery at Fortis Medical and Research Institute in Gurgaon, and has previously served as a faculty member and additional professor in the Department of Neurosurgery at AIIMS, New Delhi for 10 years. Dr. Vesh is a recipient of the prestigious Sundert Fellowship from Mayo Clinic, USA.
I think
And-
let's just skip it here.
Skip it.
Let's just go into the talk.
No, but he's amazing, and we are proud to say that he is also a valued trustee of the Parashar Foundation and has been working with us for 13 years. So, welcome, Dr. Vesh.
Yeah, thank you. So I'll share my screen now. Okay. You all can see my screen?
Yes, sir.
Okay. So, so today's topic is certification of brain death. And so can you tell me what is the kind of audience? They are all doctors or
Yes.
transplant coordinators?
No,
What?
no. Dr. Vansh, would you like to clarify?
We're all medical students here. We're all
okay.
in different years, but all of us are medical students.
Perfect. So I'll just start from the ancient times. A person was considered dead if a person simply stopped breathing. And there were violent modes of death also, like decapitation or body were quartered or they were just stabbed. So that was in the ancient times. In the middle of the 19th century, the attention was turned towards the brain. And the British law defined death as irreversible cessation of all integrated functioning of the human organism as a whole, both mental and physical. But in 1950s, when the mechanical ventilators came, a lot of these patients who were dead or who would be dead without any further treatment, they were living for longer periods, and some of them were surviving also. So that's why there was a need of change of definition of death. In 1960s, the transplant technology came, starting with kidneys, and then there was demand of organs. And that's why there was a need of change of definition. And that's when brain death actually came into picture. So Harvard Medical School in 1968 for the first time defined brain death. I'll come to that later. And in 1981, the US President's Commission for the first time said that the criteria for the brain death should be synonymous with the death of the organism as a whole. So there are different organizations, different countries, they have their own definitions. American Academy of Neurology had irreversible cessation of all function of the entire brain, including the brainstem. This was defined as whole brain death. So initially it was whole brain death, and later on brainstem death was synonymous with whole brain death. So in 1998, Australia and New Zealand Intensive Care Society defined brainstem death. Now the brainstem death is equal to brain death. Still, there are differences in definitions, criteria for brain death in different countries. So what Harvard Medical School in 1968 said was that the patient should be unresponsive, temperature should be more than 32.2 degrees Celsius, the patient should not be on any CNS depressive drugs, no spontaneous movements, patient should have apnea of respirator for 3 minutes, there should be no reflexes like swallow, gag, eye movements, or deep tendon reflexes or posturing. The EEG should be isoelectric, and there should be repeat of entire examination after 24 hours. So brain death versus natural death. Natural death can occur anywhere, and there will be complete cessation of respiration and heart function. While brain death can occur only in specific circumstances when the patient is in hospital and connected to a ventilator and heart is still beating. So And more often, these patients would be under the care of a neurologist or a neurosurgeon, and occasionally in trauma. So now the important question is, are brain dead really dead? The important question is, are they going to come back after being declared brain dead? So all these studies have shown that there's not been a single case where a person who was declared brain dead after all the proper criteria were fulfilled has ever come back. So in 1971, there was this study in US. They studied comatose patients over three months. So they enrolled 503 comatose patients, and 462 died within first 3 months. They reapplied Harvard brain death criteria to these, and only 19 patients met all these criteria, and all these patients died. So this just showed that Harvard criteria reliably identified patients who would die despite all possible support. So now there are certain emotional aspects of brain death. So there was this study which was published in 95, I think, and so 20% of the families of brain death patients continued to have doubts about whether their relative was actually dead. And this was in a society where the education level was much higher. In India, what we see particularly in North, that a lot of patients, whatever you tell them, even doctor families, they continue to believe that if the heart is beating, the person is still alive. It's very difficult to make them understand that this is not the case. Only 66% people accepted that the patient was dead, but felt emotionally that they were still alive. So again, so here there is a role of transplant coordinators and perhaps transplant psychologists in the hospital to talk to the patient's families and explain to them. So brain death typically would occur in significant damage to the brain. And those situations can be head injury, subarachnoid hemorrhage, ischemic stroke, hemorrhagic stroke, or hypoxic ischemic encephalopathy, typically seen in drowning. And then there may be other causes where there can be hypoxia. So there are certain prerequisites to declare a person brain dead. There should be an acute CNS catastrophe. There should be exclusion of medical condition, exclusion of intoxication or poisoning, and the core body temperature should be more than 90 degrees Fahrenheit. Typically, you would see three things in the patient. Patient would be in coma, there would be absence of brainstem reflexes, and there would be apnea. Now, there can be variability in the brain death determination guidelines. Are there patients who fulfill the clinical criteria of brain death but recover brain function? The answer is definitely no. What is the adequate observation period to ensure that cessation of neurological function is permanent? There is insufficient evidence for that, but that's why we do all these tests to declare brain death, and then they are repeated after a certain interval at different age groups. So are there any complex motor movement that can falsely suggest retained brain function, sometimes observed in brain death? Yes, there can be occasional flickering, which doesn't really mean that the person is alive or there is motor function. What is the comparative safety of apnea test? Because certain patients, while testing for apnea, suddenly their blood pressure or blood BP may crash. But there is insufficient evidence. What is the safety for apnea test? And are there new accurate ancillary tests for brain death? Again, there is insufficient data, but by and large, angiography is supposed to be one of the most confirmatory tests. So this year, there were national guidelines on brainstem death certification. This book was brought out by Noto, and I would suggest that everybody should go through that. Now I'll describe how to check for brainstem death. Firstly, I'll just describe theoretically, then I'll show you a short video. So to look for brainstem reflexes, firstly, you give painful stimulus to the supraorbital nerve or the nail bed. There should be no motor or eye response. Now, the pitfalls are the motor response during apnea testing during hypotension can be of spinal origin also. Secondly, neuromuscular blocking drugs can paralyze the muscles. So now we'll check for the brainstem reflexes. So the these are the various reflexes. There should be pupillary response. There should be absence of pupillary response in both eyes. Ocular movement on oculocephalic and oculovestibular reflex testing should be absent. There should be absence of corneal reflex, and again, pharyngeal and tracheal reflex should be absent. The corneal reflex is elicited by touching the edge of the cornea, which is mediated by fifth and seventh. In severe facial or ocular trauma, this limits interpretation. Sometimes the eye may be so swollen that you cannot really do the test properly. Sometimes drugs like sedatives, barbiturates, anticholinergics can diminish or abolish these reflexes completely. Now, light reflex, there should be no response to light, round or oval pupil in mid-dilated position. Again, the pitfall is in systemic drugs, they can change pupil size, and topical mydatics can change pupillary size. Sometimes patients who have been operated before on the eye may have a dilated pupil. So, absence of grimacing or eye opening with deep pressure on both condyles at the level of TM joint. Again, that is mediated by fifth and seventh nerves. Then oculovestibular reflex, absence of doll's eye movement. Vigorous turning of head from middle position to 90 degrees on both sides should have a person who is not brain dead would have movement of the eyes. But in brain dead patient, that would be absent. Again, this should be avoided in concomitant cervical spinal injury. Then calorie test. So it is done in supine position with head at 30-degree elevated to isolate inputs of horizontal semicircular canals, and instill 50 milliliter of iced water slowly, and then observe the patient's eye up to 1 minute. After an interval of 5 minutes, test the other side. There should be no tonic deviation of the eyes. Again, there are pitfalls like certain drugs like barbiturates and anticholinergics will diminish it. An eye injury or edema can restrict the eye movements and you may not be able to check it properly. Again, pharyngeal and tracheal reflexes are to be tested. You just touch the posterior pharyngeal wall and there should be gagging. Again, it's difficult to assess in intubated patients. And now coming to apnea, there should be absence of breathing drive. So how do you test for apnea? Firstly, temperature should be above 36.5 degrees centigrade and BP should be more than 90 millimeters. There should be positive fluid balance for 6 hours. PCO2 should be normal or above 40, and PO2 should be more than 200 millimeters of mercury. So normally we pre-oxygenate the patient with 100% oxygen for 10 minutes. Then you disconnect the ventilator, expose the chest and abdomen, and oxygen can be delivered at the carina with a catheter. Then you look for chest and abdominal wall for respiration for 8 minutes. I think in different texts there are different criteria ranging from 5 to 10 minutes. So during apnea test, you can do ABG. If the PCO2 raises beyond 60 millimeters or there is an increase of more than 20 from the baseline level, then the apnea test is positive. Or if the PCO2 is less than 60, again check after 5 minutes. If it is positive, then you can check it again after. If it is negative, then you can again check it after 24 hours. This is a short video showing how to test for different brainstem reflex. So this is applying pressure on the supraorbital region, and there is no grimacing or no movement of the facial muscles. Now you check for the pupillary response. Ideally, it should be done in a darkened space. Now, checking for the corneal reflex, you should normally do it from the side so that you don't damage the cornea. You should just touch the edge of the cornea. And as you could see, there was no reflex on stimulating cornea. Now, this is stimulating the pharynx to look for pharyngeal response. You can do it by inserting a catheter inside the throat also to touch the posterior pharyngeal wall. Now, the patient's head is already elevated by 30 degrees. And you instill ice cold water in the ear continuously. And while instilling the water, look for any nystagmus. As you can see here, there is no movement of the eye. And you can repeat the test on the other side also. Now, this is looking for the doll's eye movement. You open the eyes and turn the patient's head. And you can see that again, there is no doll's eye movement. So in this patient, all the brainstem death reflexes were absent. Now we are looking at the apnea test. You can see that the oxygen saturation is 99%. So you disconnect the ventilator, expose the abdomen and chest, and look for any respiratory movements. I just forward it. So as you can see, even after observing for many minutes, there was no abdominal or chest wall movement. So this is how you perform the apnea test and the brainstem reflexes. Now the ancillary test. The most reliable test is conventional angiography, either by generally done known as DSA. You can also do CT angiography, but that may have certain pitfalls. Again, the other tests are EEG, transcranial Doppler, technician scan, somatosensory evoked potential, or SPECT scan. So angiography will show complete absence of blood flow inside the brain, while the extracranial circulation can still be seen. So that is a definite evidence of complete absence of blood flow to the brain, denoting that the patient is definitely brain dead. The EEG shows 30 minutes. You should do a 30-minute recording. And so in brain dead patient, there will be electrocerebral silence. EEG may have certain pitfalls, particularly if the person is on neuromuscular blocking drugs or any sedatives. So now transcranial Doppler, this is a normal transcranial Doppler. There is a systolic peak and a diastolic, a negative diastolic curve. While in a brain dead patient, there is no diastolic thing, there are small systolic peaks. In technetium 99 scan, again, is a pretty confirmatory test. You can see there is no uptake in the brain parenchyma, and you will see a hollow skull. So here, this is an example of that. So you can see the technetium uptake in the neck and the chest, but the brain still remains hollow. So it is completely white. Again, in SSCP, there would be an absence of N20P23 response with median nerve stimulation. Here you can see that. So now, when are the ancillary tests required? In a particular situation, so many times, well, person, you obviously know that person is brain dead and there has been a significant brain trauma. There can be certain issues when checking the patients for brain death. Sometimes when you are doing apnea test, patient may crash, the BP may suddenly fall down, and you have to stop the test. So in this situation, you cannot really declare the person brain dead because the apnea test could not be performed. In certain situations, the electrolyte imbalance can be there, and these are things which you cannot really correct. A patient may be significantly hyperthermic or hypothermic. Again, you will not be able to correct in those situations. So in these particular situations, these ancillary tests are of value because there you can bypass those tests and you can do ancillary tests and then yet declare the patient brain dead. Then there are certain neurologic states that mimic brain death. There are locked-in syndrome, akinetic mutism, persistent vegetative state, severe hypothermia, and sedative and anesthetic overdose. There's no time to go in detail over these, but you can just read it in that book. It mentions all these things in great detail. Now, in children less than 1 year of age, it's more complicated. The brains of infants and young children have increased resistance to damage and may recover substantial function even after exhibiting unresponsiveness on neurological examination for much longer period as compared to adults. So when you apply the same criteria to determine brain death in children less than 1 year, longer observation periods are required. The patient should not be significantly hypothermic or hypotensive for the age. So in children between 2 months and 1 year, an interval of at least 24 hours should be used, while in adults it is 6 hours. While in children between 7 days and 2 months, the minimum interval should be 48 hours. And criteria for children less than 7 days have not been defined as yet. But why do we want to declare a person brain dead? Firstly, to save valuable resources, because then if the person is brain dead, you won't continue with expensive treatment, you won't continue with expensive antibiotics. Though the law still is gray in the area whether you can remove the patient off ventilator or not, but at least you won't waste your resources. And second, and more importantly, one can counsel the family for organ donation. As mentioned by the previous speaker, there are so many patients waiting for donation. There's a huge deficit. And if we can get even few percentage of these patients, the lives of thousands of patients can improve. So again, I'll miss that. This we have already covered. So again, he has already mentioned who should be part of the committee. Neurologist, neurosurgeon is not necessary, which was there before. Preferably, the treating doctor should be part of the team. And brain death, in most hospitals, there is a brain death committee, and any intensivist, anesthetist, physician, or surgeon can be a member of that committee. And it is the physician's duty or the intensivist's duty to identify the brain death, inform the brain death committee, and then register all brain death patients. So let your loved one live forever. So as medical students, you should understand that a brain dead person will never ever come back. So if a person is in that situation, it is a very traumatic period for the family, particularly in road traffic accident or subarachnoid hemorrhage, which usually occur in younger people, occur suddenly without any warning, and the family is traumatized at the time. It becomes very difficult to talk about organ donation in those situations. But one must realize that by doing that, you can save many other lives. Thank you.
Thank you so much, sir. It was a pleasure to have you. Before that, does anybody have any questions?
Yes,
Yes.
actually, I do. Like Sir said that there are multiple surgeons or any doctors on the brain death declaration team, right? So my question is that ethically, transplant surgeons are not allowed to declare someone brain dead. And so I'm just asking that a person who has worked so hard to reach the capability where a surgeon is allowed to do transplants. So why shouldn't they be on the board as well?
Because there can be a bias then. Just to remove that bias, the transplant team is excluded from that, while the treating doctor can be part of the committee.
Okay. Thank you, sir.
Because if the transplant surgeon himself is on the team, and suppose if the organ goes to the same hospital or the same team, then the patient's family will always have that doubt in mind whether the person was actually brain dead or whether you did this thing for the organs.
But sir, the previous speaker, like he said, there are 4 doctors who need to do it. So despite being multiple members, does one person is confound the results so much?
See, the thing is, why unnecessarily create that doubt when a hospital has so many doctors who can be part of the committee and can declare the same thing?
Okay, thank you so much, sir.
There's one more question. Sir, do we do apnea test after circulatory failure for brain death? Right?
No,
Then how systolic
no.
BP?
I can't understand. If there is circulatory failure, then the patient is already dead. How do we do it after?
Absolutely correct. Then he goes for donation after circulatory death. Then there is nothing
There's
like
no brain death.
declaration of brain death. So we have had those are very daunting situations where you have to take the patient while they are being managed by a CPR, and then they are brought into the theater, and that's how we go about it. It doesn't follow the same steps as brain death.
So apnea test would be required only to confirm or declare brain death, and that can happen only if the circulation is going on.
Yes, correct.
Okay, thank you.
You're
Thank-
mute.
Ma'am, you.
Thank you so much for coming, and we have our new next speaker now, which Aprajita will introduce.
Good evening. Our next speaker is Professor Kajal Jain, Department of Anesthesia and Intensive Care, PGI MER. She's academic anesthesiologist for 30 years and is founder of first national academic body, Society of Trauma Anesthesia and Critical Care. Dr. Jain has been actively involved in deceased organ transplant program with Roto North and has supervised more than 250 potential donors in the trauma intensive care unit, jointly with transplant and neurosurgical teams of PGI. She has been participating in outreach programs monitoring nearby states and institutes for deceased organ transplant program with Roto North, PGI. As part of that, she's here today to speak on donor maintenance, preservation of organs for retrieval and transplant in ICU. Over to you, Professor Kajal.
Thank you very much. And in this series of talks where we are concentrating on how to increase our donor pool and how to go about deceased organ donation, I'm here to talk to you a little bit about how to manage these patients once we are given this task in intensive care unit. So as the previous speakers have already highlighted, like what are the types of deaths we are going to see? It's either death after circulation or it can be from the neurological determination of death. So I'm here to speak today something about neurological determination of death. So as everybody else has also pointed out, I also believe that organ donation should be kept as an option in the end of life for every ICU patient. Because if we do not keep it, then we do not maintain these patients, and then because of the poor quality of organs being maintained while the patient in intensive care, we are not able to give them for donation. Like in my own hospital, there are so many times that we are not able to give lungs and heart and even liver for many times because of the suboptimal quality of management. And then that also doesn't help us for the decreasing the waiting list for those who are waiting for transplantation. So as youngsters who are coming up, we must make it a point that we look at these patients early on when they are towards the end of life. So what is that end of life? So when our best efforts to save fail, it's not that we create that situation. There are certain times that the patient is so sick that whatever we may do, we are not able to save the life of that patient. And this typically happens after some catastrophic injury. You do emergency care, and then you prognosticate them, and if they do not do well, then we try to go ahead with with consent for organ donation. So as intensivists, what we can do. So as the previous speakers have highlighted, now we are coming up with more open donor care units. So even if you don't have the facility to transplant, you can take care of these potential donors, and then the organs can be sent across the green corridor to the center where these transplants can be done. So it's very important that if we have these patients in our intensive care unit, we should optimize the management and recovery of organ from these patients who are no longer going to live. So it's not a very great guess to understand which patient is brain dead. So it's a mainly clinical diagnosis. So we look at the deep coma, which you just heard about, and then absence of brainstem reflexes. And then at the end of the whole scene, we confirm it with apnea testing. So this slide speakers have spoken earlier also, and it's a very important slide. So what happens is that we have to recognize these patients within our own intensive care units. Sometimes when you're caring for these patients, they don't do too well. So you have to recognize and then protect the various organs by optimizing them early on. And in our country, most of the times, much of the organ, disease potentials, they are being managed in emergency bay, and they most infrequently get a bed in ICU, but some of them do get a bed in ICU because we have really short on ICU beds. So if you have the chance to look at them in the trauma bay, then the recognition can even start there, and protection and optimization can begin right there and then. So just to reiterate the minimum assessments to declare a patient brain dead, there are certain prerequisites then the previous speakers have highlighted. So please do not declare a patient brain dead if the patient is, the neuroimaging is not explaining coma, or patient is under sedation, residual effect of paralysis, or there is a severe electrolyte imbalance, and most importantly, a extremely hypothermic patient, because the minute you resuscitate them, they start showing signs of life. So once you have finished with the prerequisites, then you must check the patient for all those things which were previously shown to you in the video, like the pupils, the corneal reflexes, and the other oculovestibular reflexes, gag, cough, and then motor response. And the final test, as we have all said, is that apnea test. This first two things are done by the intensivists. And once you're through with this prerequisites and examination, we call the apnea testing committee, in which various members are there, as were previously highlighted: a neurosurgeon, a neurologist, and then an ENT specialist, medicine specialist, anesthesiologist, and a hospital administration person. These are the people who come to your ICU, and then they do all the tests which are required for declaring the patient brain death. So as an intensivist, what we do is we optimize the function and viability of all transplantable organs. You know what are the transplantable organs. So, and then we facilitate brain death. So both the things have to be done by us. So in order to achieve this 1 and 2, we have to work with some goals. The goals which allow us to give more number of organs per donor, and also which ensure that the subsequent graft function in the patient is good. For example, if the kidneys are going, make sure that the patients who are given these kidneys start making urine after some time. So what happens when we get these patients and they become, brain dead? So soon after they lose their brainstem function, there is a profound systemic physiological instability, which you must remember from your MBBS days, like how brainstem functions. Once it is lost, at least 80 to 97% of these patients will develop hypotension because of the rostral to caudal spread of ischemia, and this will cause vasoplagia, hypovolemia, and myocardial dysfunction. So because of this, there will be also a loss in temperature regulation. So it will be very difficult to maintain this temperature at 34 or 35 degrees centigrade. They turn extremely cold. And then due to the arrest of hypothalamic functions, vasoplagia, these patients are at the risk of hormonal imbalance, and most of them, approximately 90% of them, present with diabetes insipidus, that is urine output of 5 ml per kg, or you can say in 2 hours they pour half a liter of urine. So because of the prolonged hypotension and arrhythmogenic potential, these patients are at a very high risk of cardiac arrest. And these cardiac arrhythmias are due to catecholamine release and myocardial injury. So when you get these patients and you're working on them for donation, please remember that they are extremely unstable patients, and they are not likely to survive if you do not manage all of these in tandem. So what happens? The patient is there, and most of the times the bed will be, having a stack of infusion pumps, and these infusion pumps will be carrying all very, very high doses of inotropes, and sometimes some antibiotics, steroids. So this is the kind of scene which you will witness in your ICU. The ICU dynamics will change totally, because now you are looking at a patient who is extremely unstable. So this autonomic sympathetic storm is basically due to massive sympathetic activation, which happens once there is a catastrophic brain injury. The time, mostly the organs are coming from falling head injury or polytrauma. So that doesn't mean they cannot be other organ donors, but most of the times this is what we have witnessed. And this massive sympathetic activation leads to cardiac damage and endothelial damage, which in turn increases the left atrial pressure, pulmonary vasoconstriction, and then this causes pulmonary congestion as well. So all acute lung injury goes on. And if it's the case of trauma, then these patients must have lost a good volume of blood. They may not have been adequately resuscitated in trauma bay, and due to large volume crystalloid resus because of the hypotension and difficulty in maintaining blood pressure, we at times give lots of crystalloids. So there is a decrease in oncotic pressure. And if it's a head injury patient, the patient may have also received osmotherapy using mannitol. And put together with the endocrine changes, there is a big deal to manage in terms of fluid deficit. So clinical assessment of volume status is even more challenging in brain death versus a general ICU patient. So you're confused whether this loss of volume is because of the central sympatholysis, or it is because of the profound peripheral vasodilation, or is it a central diabetes insipidus. So you have to be really looking at all this, because you are targeting a mean arterial pressure of at least 60 to 70, and an ejection fraction you should try to maintain more than 45. There is no evidence, but we all know that we are looking at good transplantable organs. So these things are required, because you do not want that the patient's kidneys or liver or whatever your organ is being transplanted should not be functioning properly. So how do you pump up your blood pressure? What are the vasopressors and inotropes which you are going to use? So mostly there were people who were recommending the use of dopamine, because dopamine is good for the kidney function, but dopamine is not good at higher doses. So at a very low dose, 5 mics per kg, which is not going to suffice to bring up the pressures. So we are not using dopamine. If you use higher dopamine, then that causes bradyarrhythmias and tachyarrhythmias. So the drugs of choice for us are norepinephrine, which has got both alpha and beta action. So it causes a peripheral vasoconstriction and also works on the beta-1 receptors. If you are maxing out your dose of norepinephrine, it will be good to add vasopressin, because vasopressin also acts as antidiuretic hormone. So you also have a patient who's having DI. So these two drugs would fare better than dopamine. And this has also been seen in many graft survivals after kidney transplantation. So if you give noradrenaline, they have seen that the graft function rejection losses are decreased. However, norepinephrine, it causes intense pulmonary capillary permeability, and then there is an extreme degree of mesenteric and coronary vasoconstriction. So it may not be so useful. Some trials have shown for brain dead cardiac donors. So when you're using this in max doses, try to add another drug. So that's what I talked about earlier. So you can add vasopressin. You try to do hemodynamic monitoring using central venous pressure, which gives you the trends. You also look at the lactates and mixed venous oxygen saturation. And what helps you the best is point of care ultrasound. All of us know that these days we are trying to learn how to make the window through sub-xiphoid view and do serial echoes. So you can see the left ventricular contractility and the ejection fractions, and then you can try to do volume resuscitation. When you're choosing your volume resuscitation, you have to remember that you cannot choose any of the fluids. Be very careful. We are not expecting any one of you to choose hetastarches, because they're associated with graft failure, renal graft failures. If the patient's sodium is very high, most of the time it is. So we recommend the use of half normal saline. So there is a full algorithmic approach, which you all can go through from any of the books. So basically in our center, we are using a combination of half normal saline with the free water correction. And this has to be done very rapidly. Here, we are not going to think about central pontine myelinolysis, because this patient is brain dead. Here, the time is ticking very fast, because we have to make the patient fit to undergo apnea test within a very limited time. Because, as I said earlier, the patients are extremely unstable. So the choice of fluids should be based on the electrolytes, and most commonly we are using half normal saline, and we are not using 0.9 or plasma lights. We are mostly using half normal saline. And if the chloride levels are very high and potassium levels are low, you can go in for potassium phosphate. So whether you should go conservative or very liberal about the fluid management. Because if you go very conservative, it may benefit the kidneys, but it may not benefit, it may benefit the lungs, but may not benefit the kidneys. That comes to our mind because we all think about pulmonary edema when we are giving copious amount of fluids. But you can be guided, because it has been seen that even if you do restricted fluid therapy, it does not have any detrimental effects on kidney graft survival. I'm not here to talk about venous congestion, but nowadays we are also talking about deresuscitation and measuring portal venous pressures and renal vein pressures to understand whether the fluid accumulation is also affecting the blood flow to the kidneys. So if you do a balanced approach, you can even have no adverse effect on kidney graft survival. Try to keep hematocrits at 21 and don't think that the patient is brain dead, so we do not need to give blood transfusions. We do give lots of blood transfusion because we are targeting a hemoglobin of at least 7 grams, like a hematocrit of 21%. But I would be happier to have even higher, because with such low hemoglobin, it is very difficult to maintain blood pressure. So this is the minimum we keep, but we go up to 9 and 10 as well if we are not able to keep up the pressures in that particular patient. So since these patients are very prone to lung injuries due to the catecholamine storm and also due to the inflammatory cascade and neurogenic pulmonary edema, along with ICU-related complications. So patient is in an ICU, patient can have VAP, atelectasis, ARDS, and then chest trauma, aspiration. There's so many things which are bothering the lung. So you have to also take care of X-rays like this, because at the end of the day, you're preparing the patient for apnea testing. And when you disconnect such a patient for apnea testing, he will desaturate and your apnea test will be terminated because your patient is not ready to take it. So you have to be very careful that you decongest these patients from time to time, put them on broad spectrum antibiotics, and then give a little bit of positive end expiratory pressure so that you can improve the gas exchange. So these are some parameters which we have to follow. We have to try to bring PaO to 200 mmHg, and this is all because of oxygen dissociation curve. If we are at the plateau phase of oxygen dissociation curve, then during apnea testing, we will get some time before the patient starts desaturating. That typically happens when PaO2 drops below 60, and then it has a very steep curve, and again, you will have to terminate your test. So try to keep your oxygens above 100, and these are the kind of airway pressures which you can manage through your ventilator. So always be mindful of the failure of hypothalamus and the alteration in thyroid axis and temperature regulation due to pituitary dysfunction as well. So whereas there is also a risk of diabetes insipidus because of the posterior pituitary function and depletion of ADH. And as I already told you, rule of thumb, how do you classify your patient being in diabetes insipidus is 500 mils of urine output in 2 hours. Management of DI is the same as you would have ever read in your book. So I'm not going to read this chart. So we are using desmopressin spray. So when you're doing all this, please watch out for sodium, because once the patient starts losing too much of urine, he becomes hyponatremic. And once you start restricting, then becomes hyponatremic. So this is a big game of sending samples repeatedly to understand sodium, because the cutoff for sodium for brainstem certification is in our institute less than 155. So not many recommendations are there to give antithyroid drugs, but if your patient is extremely vasoplegic, not able to maintain blood pressure, and myocardial dysfunction is profound, then you can add thyroid supplementation, which is like typically 200 mics OD we give through the Ryle's tube. So you can monitor temperature anywhere, but it's recommended that you monitor only central temperatures. We try to keep the patient warm with forced air warmers. And then you can also, if you don't have one, then you can use warm fluids and cover the patient with blankets. Be careful if you're putting hot packs, patient should not burn. And then that's how you have to maintain temperature, because apnea testing will not be done if temperatures are less than 35 degrees centigrade. So some of the times patients also get coagulopathic. So how coagulopathy is going to affect you? Because in such a case, the patient can have passage of necrotic brain tissue into the circulation. So it's important that you understand this factor as well. So I have already talked about management of sodium chloride, hypokalemia, magnesium. More important to understand in this slide is that these tests are repeated very frequently till you get them into the target range. So it doesn't happen that you do at 8 a.m. in the morning and the next happens at 4 p.m. Mostly in my own ICU, we try to do it every 2 hourly to correct them very rapidly, because these patients turn unstable in no time, arrest, and then they're difficult to revive because they're extremely hypotensive and acidotic. So it's very important that you rapidly correct and bring up these patients for for apnea testing. So similar to thyroid, we are not supplementing corticosteroids unless the patient is extremely vasoplegic. And otherwise, there is no role of corticosteroids in the normal practice. But that said, I am using corticosteroid for most of my patients because we receive these patients very late, and most of our patients are already in sepsis and septic shock, along with being into vasoplegic shock because of their brain death. If for some patients who are to be posted for lung transplant, the use of methylprednisolone is particularly beneficial because they help in reducing leukocyte antigen expression, and then this is recommended for those who are undergoing lung transplant. Don't forget to do general care of these patients. Don't think they are dead, they don't need anything. So we do follow all the hand hygiene, eye precautions, bronchial toileting, postural changes, and above all my patients are also put on a trophic feed, so they get a minimal amount of calories through the day. This prevents translocation of gut bacteria. And we also do heparin DVT prophylaxis, because the small microthrombi which get formed also clog the renal and lung vessels. So this is not good for the transplanted or the grafted organs. So as the previous speaker had already highlighted the basics, the prerequisites for apnea tests. So this is, I think, in all ICUs across, we go around with this kind of figures when we call the team for doing apnea testing. So apnea testing is tested to be positive if the pre and post shows a difference of 20 mmHg. In my center, we are waiting for at least 8 minutes. So it's 3 mmHg rise per minute. So if it's 8 minutes, it's 24 mmHg rise. So if you start with 40, it automatically comes to 60. But if your patient is, giving you a little more time, you can even wait for 10 minutes also. So this is one ABG from my own system. You can see how the carbon dioxide levels have shot up from 41 to 86. So apnea test can be repeated for, as I've already said. And then there are certain observations which also become compatible with brain death. Sometimes you see spontaneous limb movements due to spinal activity. We have seen it very often. There are bilateral finger tremors, leg movements, deep tendon reflexes, triple flexion response. Babinski's reflex in 55% of patients. This is very confusing because when the patient shows these movements, then neurologist does not clear the patient for apnea testing, and then you have to again wait till till 8 hours. You can't repeat these tests again. There is a definite interval attached to it. You cannot do it anytime you feel like. So other things which we see normally are facial myokymia, microtremors, respiratory-like movements, sweating, flushing, tachycardia, normal blood pressure without pharmacological support, or sudden increases in blood pressure. So these things are, they have to be seen in with, the neuroimaging and the trajectory of the patient in ICU. There are other signs which tell you that this patient is brain dead, but these features are not compatible with the diagnosis of brain death. So this is one of the videos. Sorry. So you can see here, as you had seen, the previous speaker was showing you how they are giving central stimulation. So this is after the central stimulation that you can see patient is lifting his hand, and this would confuse you whether this patient is showing a response or is brain dead. So if you have enough evidence, like your other features are suggestive, oculocardiac, cephalic, and oculomotor reflexes are gone, and you have fulfilled all the criteria, then this may be just compatible with spinal activity. So we have gone ahead with the ancillary test. My institute does not support ancillary tests. We go ahead with only brainstem apnea testing. It's on a very, very high threshold that once or twice we have performed ancillary tests. Otherwise, all of them go through the apnea testing only. So for making a successful donation after brain death, it requires early detection and referral, and we need to adopt certain checklists. And then we have to know what are the management strategies fundamental to increase the number and quality of organs for transplantation. We should have a very good interactive in ICU operating of professional transplant coordinators, which is very, very, I must say, comprehensive in my center. So that is why we have this figure of around 300 potential donors being done by us. So we as intensivists, we are playing a very key role in organ donation processes. And this is a very noble cause because we all know that there's a great scarcity of organs, and so many patients are waiting for organ donation. And therefore, as youngsters, we must take it up very effectively through these kind of webinars. And when you are wheeling in your patients for harvesting, please do not forget to pay obeisance to the departing soul, because they are departing on a very noble cause. So also be a hero by registering an organ and tissue donor today, and also be someone else's hero also. Thank you so much.
Thank you so much, Dr. Kajal. Since there are no questions, we'll move on to the next speaker. We now have Dr. Vishali Sulao, MD, F&B, Head of the Transplant Critical Care Unit at Jupiter Hospital, Pune. Dr. Sulao brings with her 25 years of experience in critical care. She's a recognized Dr. NB teacher and IDCCM teacher, and is a member of both the Indian Society of Critical Care Medicine and the Liver Transplant Society of India. Dr. Sulao's areas of interest include liver failure, cirrhosis and its complications, extracorporeal liver support therapy, and infection control in the ICU. The topic that she's going to take up is here, breaking bad news, addressing the family of the deceased. And later this evening, Dr. Sulao will also be giving guidelines on the role play. Thank you so much, Dr. Sulao, for joining us today. Over to you.
So thank you, Sunaina and Organ India, for having me here. And I feel this topic, which has been given to me, I feel privileged. I'm going to share my screen. Just let me know if you can see my screen. Okay. So I think the series of lectures so far, have prepared you with the science of brain death, and how to determine it, how to maintain a donor. And that's the basic core skill any intensivist or anybody handling such a person, such a patient should have. What I am going to discuss is the human aspect of this entire process, and which tests your humanity. And so this turns out to be a much more challenging part of the entire responsibility than the previous steps of actually identifying, maintaining, and maintaining the quality of the organs. So in the next 10 minutes, what we are going to learn is how to prepare before breaking the bad news, what to anticipate while you're breaking the bad news to the relatives, I'll briefly describe a protocol which is universally used most of the times all over the world, called Spike's protocol for breaking bad news. Something about a warning shot, and then of course also identify the resources and support needed to break this bad news to the relative. Now, what is bad news? Obviously, in this scenario, which we are talking about, it is revealing to the patient's family that the patient is brain dead. Mind you, it is one of the toughest conversations to have with the family, especially in India. I worked in 2 more continents, and it still continues to be the most toughest thing in India because one, the uniformity of knowledge across the spectrum of patients is not there. Some patients are very well informed and they already know, they've read, but some can be from rural background and they have zero clue about what brain death is or what organ donation is, though they may have heard of organ donation in the periphery, but they just have zero understanding of it. So it tests you much more, your communication skills, your patient listening and trying to sort out each of their questions is tested to its limit. Now, how to tackle this difficult conversation? So first, let's understand the intentions. What are the core values of this conversation? The first is the intention. The intention is to convey to the family that their loved one is brain dead, right? This itself can be a complete one family conference of nearly 20 minutes because it takes time. They are in shock. Sometimes they're not ready to accept. Understand that most of these patients are usually young trauma patients. And, imagine an 18-year-old boy and trying to explain to the parents that their child is brain dead. It takes time, right? So sometimes this itself takes one whole family conference, and then you have to give them time to process this and then proceed with the next steps. The next is basically explaining what is brain death. Many of them, I would say in my experience of nearly now 15 years of counseling for brain dead patients, still 65 to 70% of the Indian population do not understand brain death very well. And of course, they are in such shock that at that time, they don't even have the ability to absorb all the information that you're giving in a right manner, and they get confused by all the information overload they are bombarded with. So you have to be very patient in explaining what brain death is. Then, of course, what is the outcome you want out of that conversation, out of that connection with the family, is that you want them to consider organ donation, preferably. Now, often this is not one single conversation you are having on one day with the patient's family. It's usually a series of counseling, depending upon how stable or unstable the patient is, of course, in the ICU. And it's usually a series, maybe spread over 2 days or 3 days. Of course, this depends upon how unstable the patient is. Sometimes the patient is unstable, and then you may have to hold the conversations in a very short span of time, and that doesn't give the relatives enough time to absorb the information, and that may work against the cause of donation. So the goal in general, breaking bad news is a part of medical practice. You're all medical students, and I guess you're going to be breaking bad news no matter which area specialization you work in. You're always going to require to break bad news, either to the patient or to the family. Now, it's a skill which is you get better at with years of experience by observing your seniors, by learning from their mistakes. We all commit mistakes in the initial 10 years. There's a good conversation, there's a bad conversation, and once you see some examples, you realize that, okay, this is probably not the right thing to do. So the goal is to first talk to the relatives, find out what they understand about the patient's condition, what is their current level of understanding. Even though you may have been counseling for the previous few days that the patient is quite bad, the brain injury is quite bad, mind you, they're going through their own phases of grief, and they're usually in denial. And so they don't absorb that we have been telling them that the patient is extremely critical and that the brain injury is catastrophic. So begin with asking them about what their perception is about the patient's condition. In case you do find that the perception is not close to the reality, then you must convey the information in very clear terms, using very simple language to bring them to up to speed with the patient's current condition, and that is brain death. Now, another important goal is, of course, providing proper psychological support. Mind you, they're going to be absolutely devastated by this news of brain death, and you need to be able to anticipate that and give them all the assistance that is required for them to be able to cope with this news. Never give this news and then just disappear. That's abandonment. That is not sharing their burden, and that creates a lot of mistrust, and that is the first wrong thing that you will do. And then the likelihood that you will get consent for organ donation goes down. You have to hold their hand, and you have to tell them that you are there for any of their worries, questions over the next whatever 24, 48 hours they need to make a decision. And of course, sit with them and then make a plan about the next steps. Right? What are the major hurdles and what can go wrong? The big hurdle is, of course, the doctor's own emotional state when you don't want to be delivering a bad news to a family. And this is natural. We are all human. We are very happy to give good news. We are happy to say that, okay, the worst, especially in ICU, I've been an intensivist, and after 48 to 72 hours, if I see the organ failure recovering, I'm very happy to go and tell them, yes, there is a patient is showing signs of recovery, and we have the worst is over. But then actually telling the patient's relatives that probably everything that we have done has not been helpful and that the patient is brain dead is quite challenging. So that itself drains you, that you have to deliver a bad news to the family. Then unpreparedness. This is another hurdle, and which doctors struggle with, is that you're not well informed about the patient's condition. So that is where the preparation part comes before breaking the bad news. Be prepared with every information about that patient. Maybe it's scan, maybe how the accident happened, because you need to be able to demonstrate that you have full knowledge and about the patient's situation right from the beginning till such point that he has reached the stage of brain death. Give time. Don't be in a rush. Your body language should not communicate that, okay, you just want to get over with this task and move over to the next task. This creates a lot of, Sunaina also told me about one incident which she experienced recently with one of the doctors. This creates a very dissociating experience for the relatives. Give them time, give them all the time that you can give them. And of course, the doctors are always worried about unleashing a reaction from the relatives, may it be anger, sometimes, yes, and we all have experiences of getting unexpectedly angry reactions from the relatives. It's natural. They are not in a stage to accept it. So that has to be dealt with kindness and understanding. Now, there are many protocols, out there about how to break the bad news. And one would ask the question, do you really need a protocol for breaking a bad news? It's a human conversation, one human to another human. Why do we need protocols? So basically, the protocols only make it easy for us so that we don't miss out on any aspect of how to break a bad news to the relatives. And it creates a structure in my mind that what am I going to do? Step 1, I'm going to prepare first. Step 2, I'm going to set up a setting. Step 3. So this is the P-Spikes protocol, which is, as I was telling you, is commonly used everywhere. The first is preparation. Be informed about everything about the patient. How did the accident happen? What is his background? Who is in the family? If you know that will be great. But of course, you can always ask that in the family meeting. But if you've been counseling the relatives, which we intensivists always do for the first 2-3 days, then you usually know the background of the patient very well. Then you set up the meeting. Now, please do not hold this conversation in the corridor or by the bedside, because you don't have the time to go to the conference room and sit down and have a chat with them about this. That is that's very unprofessional, and probably they may not be able to absorb it in an inhibiting environment like in the middle of the busy ICU. So take up a meeting room, ensure privacy so that other patients or other patients' relatives are not listening to this conversation. Involve all key family members, identify them by their names, relationships. Try to involve, if you have an ICU counselor, a grief counselor, excellent, that only helps you. The nurse, definitely. And if you have a transplant coordinator in your hospital, then even he or she also is a excellent addition to this team. And avoid interruptions. Please don't take mobile calls while you're having this conversation with the relatives. Try and keep the interruptions to zero, not minimum, but zero. Then the next is in the SPIKES protocol is perception assessment. Ask the family about their perception. What do they think their patient status is, what happened, and are they completely up to speed with what is being done and what are the results of whatever has been done. Then, of course, this is in the scenario of when you want to break the news to the patient that he has a cancer, but here invite the relatives to be a part of the conversation, not the patient himself, unfortunately. Then give knowledge and information, right? Once you want to tell them about brain death, you have to inform them about what is brain death. Now, sometimes in some volatile situations, especially young children, with parents, it's better to give a warning shot by telling them that, look, I don't come with good news. I'm afraid that it is a very bad news. And so this is a warning shot. You're already preparing them for the conversation over the next 10 minutes. This warning shot gives you depending upon their reaction, gives you an idea whether you should be completely sort of being revealing them about the brain death, or take it slow and give them another chance and have another conference maybe later in the day, or maybe next day, to be able to assess by assessing their reaction to this warning shot. The biggest thing that must be the communication should be empathetic. You must be sensitive, and all your verbal and non-verbal cues must exude empathy. And then once you have given the knowledge and information about the brain death, then you have to form a strategy for the next step. What is the next step after brain death, right? Then you have to give them information about how the next steps are going to shape up. Just to emphasize, empathy is crucial, and that is why AI will never replace us intensivists, because we talk to the relatives every day, day in and day out. We share their burdens and we share their vulnerability, which AI will never be able to do. Fake empathy is not real empathy. And so, yes, humans will be needed for that connection, and that make every attempt to connect with the family. I know it can be emotionally a burden, but it is essential in this scenario, at least, where you want an outcome of the family cooperating for organ donation. At the end of the meeting, please have an exit strategy. Don't leave them, abandon them that, okay, he's brain dead. You do let me know if you want to go for organ donation. No, you tell them that, yes, I've given you so much information. You may take time to absorb this information. You may have questions, and they usually have questions because they have not absorbed all the information. Give them a contact point, whom to contact in case they have questions. May also tell them that you are available whenever you are on the ward or on the floor. But in your absence, the nurse, the transplant coordinator, or the social worker should be available to answer all their queries and make the next steps clear for them, because trust me, they sit outside in the waiting area and more questions come up. I usually tell them that you sit for the next hour or so, whatever questions come up, write them down on a paper. We'll have a follow-up meeting, and then we can try and answer all those questions. That helps them also and us also. Give them time. As I said, give pauses in your conversation. Don't be in a rush, right? And use clear language and terminology. Don't use ambiguous terminology. Say brain death is brain death. Do not be circumlocutive about brain death. He has lost this reflex. He has lost that reflex. No. say that we have conducted the apnea test, the first apnea test, the patient does not have any respiration, he's brain dead, right? So use clear terminology and do not give too much information and do not withhold information also. Things to avoid, as I said, the first I'll tell you is do not keep talking all the time. Don't make it a monologue. Give breaks, give pauses, ask them whether they are understanding what you are saying. And once they agree that yes, they are understanding, only then proceed with your further conversation. Don't make it a monologue. Don't be judgmental. And I'll tell you how that judgment comes in. Sometimes some questions come up which kind of sound bizarre to you as a doctor, but they are absolutely natural from their point of view. And so don't judge over their questions. Don't give them any false reassurances. As I said, don't overload them with information. Now, in case of brain death, as I said, preparation will be that you are well informed about what is the brain injury, what does the scan show, what was the procedure done in case the patient underwent neurosurgery, and what has been the progress after the neurosurgery. In the setting, please bring them to a conference room and preferably with a grief counselor, maybe one more neurologist if he was in the treating team. A transplant coordinator or a nurse should be present. Ask them what is their understanding of the patient's condition. Then give them a full scope of the patient's condition in case there is a dissociation between their perception and reality. Then explain brain death in details, use simple terminologies, and validate their grief. Share their vulnerability by a simple sentence that I can understand that this is a shock to you and that we understand your grief, but this is the reality and that your patient is brain dead. Now, the next step is, of course, requesting for organs. Often, it is best not to combine this with the declaration of brain death. The first, as I said, warning shot, you tell them that we think that the patient is brain dead. We have done the first apnea test. We can, sort of confirm by the second apnea test. Decouple the donation request if you have time. If you don't have time, patient is unstable, in the same conversation, you have to approach them for considering organ donation and respect their autonomy. If they do say no, then you have to respect their autonomy and then go for comfort care, right? Always, there should be a person of contact. Usually in our scenario, this is a transplant coordinator who's available, and we provide his number to them so that they can call him up and ask about any questions. Sometimes they have simple questions like, what time will the body be handed over to us? And usually as doctors, as intensivists, we are not aware of all this, and the transplant coordinators do a beautiful job at maintaining that constant line of connection with the relatives once they have made up their mind about organ donation. There can be many questions in the family conference that come up. And trust me, in the last 15 years, I used to think that nothing would surprise me. And yet there would be some questions which come up recently. A patient's family who are from a village, when I asked them about considering organ donation, they were like, the question they asked me is that you are asking our patient's organ for other patients. Why can't you give somebody else's brain to our patient so that our patient survives? And so, as I said, don't judge them, answer patiently, and do not respond to negative comments in kind. Some of the family members maybe in the phase of anger and denial, and so may respond with negatively. The mistrust there is mistrust in the Indian community about healthcare, and then they might be saying that you're doing it for your vested interest. The hospital one has vested interests in this. Do not respond in anger. Be kind and answer very patiently. So basically, respect their autonomy, be human, be sensitive and be empathetic, and be available to them for their questions if they have any, once you have given them this information that the patient is brain dead. Thank you very much. There are many websites where, all this information about brain death is already online. You are a very privileged generation that you have access to information so easily. We used to be, we have learned it the hard way. We've observed our seniors. We've made our mistakes while counseling, and we've come to this stage today. You will see a lot of YouTube videos about counseling also, what is the good news, a good way, and the bad conversation. So please practice this as often and be well informed so that you do a better job than us in this. Thank you so much.
Thank you so much, Dr. Vaishali. Okay, we'll move on to our next speaker now. So we have Jasmeet Anand with us. She's a dynamic healthcare professional with 20 years of experience across hospital administration, academic programs, clinical excellence, and organ donation and transplantation. She is currently the manager deceased organ donation program at Max Super Specialty Hospital, Saket, where she works to strengthen the organ donation program and support related initiatives across the hospital. Jasmeet also has been closely involved in awareness and transplantation initiatives throughout her career. A passionate and people-oriented professional, she's committed to creating hope and making a meaningful difference in the lives of patients and families through organ donation and transplant. Thank you so much, Jasmeet. She'll be speaking on providing compassionate grief counseling to donor families approaching the family for organ donation. Over to you, Jasmeet.
Thank you, Prajita. Thank you, Sunena. Thank you, whole Organ India team. Thank you, Dr. Vishali. It was really a very great session. And yeah, I'll just share this.
Vaishali, ma'am, if you can stop sharing the screen.
I'm just trying to do that.
Should I share the screen on behalf of her?
I'm just trying. I won't be able to handle.
Okay, no issue.
I'm so sorry. I won't be able to do that.
You're not able to share the screen, Jasmeet?
No, I won't be able to share that screen. I don't know why.
Is it?
Yeah, I'm trying to share entire screen.
Okay.
And what is happening?
I'll open it for you then.
Okay, that will be great.
But somebody's opened it.
Okay,
Wasn't
I
it
think
you?
is that no?
I
it's
have
not.
opened it. I have opened it.
Okay.
Yeah.
Make it a little larger.
Yeah.
Okay, thank you. Thank you so much. Stop. No, okay. So thank you very much, everyone, for giving me this opportunity to be here in this forum to discuss about grief counseling and the family approach. So, so what is exactly a grief? So grief is a natural emotion response to loss, and it is like coming towards to the family who's in grief, understanding their loss, and we have to understand each and every point from their side, and then respect their decision accordingly. Right? Yes. Next slide, Saurabh. So while we are understanding the grief, so it is very important. So I will go with the real based situation when we we approach to a family. So whenever when in ICU, the role of coordinator is very important, wherein we are going regular basis to ICU to identify the brain dead patient, and wherein it is also the equally responsibility of the primary team and to let us know about the reality of the patient and exactly what the patient is going through, and whether we have to approach, when we have to approach to the family, right? So while we know that there is a brain dead patient, so it's our responsibility to check at the back end the whole story of the patient, the complete history of the patient, diagnosis of the patient, so that before we speak to the family, we understand the right and correct diagnosis of the patient and how we have to handle the family situation on real basis ground, wherein we have to check lot many points towards their family history, towards their relatives, to have understanding about exactly what the patient has gone through and who all the family members are present there, knowingly that that their young one, their near one have no more. So we have to start communication with the family. Before that, we have to ensure all that point, wherein obviously psychology support, which we have to provide them. We need to speak to the doctor first regarding the patient and the family, what their understanding about the acceptance of brain dead, and whether we talk to the family about the same, what information has already been given to the family through a doctor. Yes, it is important that patient is brain dead, and we have already the primary team has already been given little information about the same, and then we have to go to the family to understand, introduce ourselves, but we have to ensure, as Dr. Vishali has talked about, that all the communication has to be happening in the closed door, not on the corridor. We have to sit with the family, give them a time, introduce ourselves, letting them know about the brain dead condition, and listening from them exactly what they are going through, holding their hand, sitting with them, know the right, what exactly their feelings. We have to come into their shoes to know the real scenario, to know the real grief from them, listen to them. So this is the time when the patient family is in shock, and and in shock they can behave any of the ways. They may be, sometimes they can be angry, they are angry on us. They will not accept that fact the patient is brain dead, and why we are talking about for donations. So this is something, but where we have to stop back ourselves, and we should not rush about anything on organ donation, right? The first thing is, can you please move the slides? Saurav, can you please move the slide? So here I already discussed about that we have to ensure the medical information is clear and consistent. So we have to go through the patient file thoroughly to know the condition and the background of the patient. We have to identify the family, who all people are available there, who can be a decision maker. So this is very, very, very quiet. And yes, we have to be silent. We have to just observe what is going around. Just contact the key people who are actually, we are working in the hospital after this program, right? So knowingly, we our staff, all the staff, ICU staff, and everybody towards this program, who are the key members, who should know what exactly, if this happened, what step we have to take forward. So everybody is quiet and just observing and listening to what is going around. So it is very important to know all the information about the family and their emotion. We should not talk directly to the family. We have to stay back and just observe what exactly emotions are going through. And yes, it is important to speak to first doctor and understand, and then again, connect to the family. So it is very important, like when we are talking to the family, we should never talk all alone, that there should be some one critical care doctor should be present there, or the primary team neurosciences team doctor should be there, so that it will be easy. There are so many medical things which family again and again check over, talk about, wherein it is always important that the right information should be flow through a key person. So it is important that when we are talking to the family anything about brain death of the patient, so it is important that the key member should be there. So can you please slide? Yeah. So it is important. So when I will say that the roles start, we have to connect with the family knowingly. Just ask humbly what exactly has happened to the family, to this incident. What happened to the patient? I mean, so the thing is that the family should not feel like the counselor who is there to listen. So the moment this whole situation started, one person has to come into same platform where the family is there, right? Listen, ask what has happened up toward this incident. So this slowly opens, and yes, holding the hand, like Dr. Vishali said, we should always hold the hand, talking softly, and listen what went wrong. So after hearing everything, we should not force for anything. Yes, what did doctor has talked to you about it? What is their understanding on brain death? Whether they accept, whether they understand this fact or not. So it is very important connect to the family, because obviously when you're there, you have to introduce yourself, establish trust, listen to them, inform, explain the medical facts clearly and simply. So it is very important to understand what they are going through, their feelings and everything. So with that, we just have to just slow down everything, wait for the time till the family comes up their own self, saying, telling whatever is their decision. So it is very important that understanding about the family's feeling. So move the slide, please. So communicating with a bereaved family. So we have to be very sure do's and don'ts, what we have to talk and what we not. So it is very important that we have to sit with the family and then listen to them, but I already speak about it. So we have to use simple language to talk to the family, and obviously we have to be silent and then listen to them more. And then obviously when family into different emotion, where the family is,
We can't hear you.
you can't hear me?
Yeah, I mean, at least I missed last few minutes. Were others able to hear her?
Yes, ma'am. I can hear you clearly.
Okay.
I can hear you
Okay,
clearly.
I'm sorry.
Okay. So it is really important that we have to be into the shoes of family, wherein if they are crying, it is very, very emotional situation when family is crying, and when you are actually attached to the family and listening to them everything, and then you also feel like emotionally connected with them, and then you can make your connect to the family more and more, and tell them that you are present there and you'll be here all around, and you are there as their support, help, anything related to this situation. They need any clarity, you are the spokesperson. You can come back anytime, share your mobile numbers, talk to them, and then they can anytime point of time they can come back and check any details, whatever they want, be it anything. And we have to ensure that we have to respect them in every way. It's not about it's not about organ donation. It's all about a family who is in grief, and wherein we have to come forward to support that family towards anything in the hospital, be it be it, I mean, front office till any of the department which all over involved, and we have to let them, allow them to question us, and we should give answers in a right manner, with the complete information and the correct information. And we have to be very much close to the family all the time. So we should never be rush or pressure to the family about organ donation. And it is very important that medical clarity should be given by the doctor. So we are the pillar wherein we have to balance that which information has to be passed on to the family and how. Next slide, please. So a compassionate transition. Would it be okay if we talk about something that may be important to your family? Did your loved ones ever express their wishes? So it is very important when family is settled down, a day or a day two, they come back to us again. They wanted to initiate, or at the midnight they want to talk about this. So we have to talk to the family about exactly what information they needed. So we have to ensure then when we are introducing about the organ donation, right? So we have the team of the people are there and letting them exactly know about what is brain dead and how what. Okay, the role of NOTO, National Organ and Tissue Transplant Organization, comes here, because they need exact clarification about how this process will move, what exactly will be the process of donation, how it happens, who will be getting the organs. So these are the different questions family comes up and ask for the clarity. So we have to tell them there is a proper protocol wherein every hospital is connected with NOTO. NOTO is again the central authority which who the government body decided which hospital will get organ and which patient. So whenever donation happen, any alert happens, when families say yes after giving the consent, we raise the alert to NOTO, wherein NOTO decided the NOTO raised the alert to the organ allocation group, wherein all hospital gets alert and how the organ donation, organ allocation happen. Next slide, please. So this is something support after the decision. Whatever the decision, we have to continue the support. So it is very important. Family will not say yes in one go. They take time, maybe 1 day, 2 days, 3 days. Maybe after they gave the consent on 1 day. day first. And we have started all that formality towards considering for the organ donation. By mid of the night or next morning, the family say no to it. Then it is absolutely okay, even if everything is channelized or every authorities are informed, still, if family has a right to say no, even before or after patient wielded OT. We have to regard the family decision, and at that time we have to, uh, we have to be with the family with their decision, whatever is their decision. We have to respect their decision. And yes, obviously, at every time, our role to give them clarity towards donation, and we have to maintain the regular communication with the family, and whatever their questions, we have to answer them, and we have to understand exactly what things are going on. And yes, once families say yes, we'll go ahead, and we have to inform the authority later if family say no. In case, we have to honor the patient. So this is important, the role of coordinator, where we have to listen with empathy, understand the family grief, communicate clearly, respect choice and beliefs. So support throughout the process, preserve dignity. So we are not simply asking for a donation, we are accompanying the family through one of the most difficult moments of their life. And we are there with them. And we ensure that at every step, they are comfortable. So it is our responsibility to give family a whole comfort. Change the slide, please. So, so grief comes before the donation conversations. I build trust before making the ask, listen, knowledge, and allow silence. So use simple and compassionate language, what the family understand. Explore the donor values and wishes, and respect every decision at any point of time. So we always there to continue support family even after donation. Thank you.
Thank you, ma'am.
Yeah.
Do we have any questions now? If you have any questions, you can send a message in the chat, or you can unmute yourself and ask the question.
Otherwise, let's move on to the last bit, which is the role play. Okay, so I think everybody has got the guidelines, and we have certain people who want to make we have 3 groups, I believe, 3 teams who want to make it. So Dr.
Yes.
Salah, can you, I mean, they've already received the guidelines, and there are 3 scenarios, I think you have
Yes.
come up with. So how do you want to do this, Pujita?
So yes, ma'am. So as according to the guidelines, we have divided the participants who have interested in the role play into 3 groups, giving them the 3 scenarios, and we have given them the guidelines that they have to record the video in the Zoom and send us by tomorrow afternoon, and we will be forwarding the videos to you in the drive, through the drive link.
Okay, so Dr. Salah needs to get that because she'll have to look at it before tomorrow's.
Yeah.
Yeah.
Yeah,
Yes.
so if I can get that at least a couple of hours before the
Right. Any particular
we could-
takeaways? I mean, guidelines you want to just reiterate, Dr. Salah? Any particular?
So I think there are people of various experiences in the audience. Some may be sort of beginning of the medical career, some may be a bit more advanced. I'm not too sure. Some may be also in their internship or post graduations, right? So when it comes to, I would say that when it comes to the
Sorry, ma'am, you're not audible.
You're breaking up, so maybe you can put off your video.
Oh, sorry,
Yeah, I said
I'm not
you're-
audible.
No, you are breaking up, so if you want, you can put off your video. Maybe that'll help.
Okay, sure. Yeah, I'll do that. Yes. Yeah. So my suggestion would be that the counseling doctor should be somebody who has actual clinical experience. So maybe if he's a postgraduate, will be better than a first or a second year medical student who has no exposure to counseling. Forget about counseling about brain death. So try to choose in the team the senior person who with relative some experience in clinical scenarios as the doctor, and the others to in the family who are family members of the patient who are going to ask the questions about their patient. Do you get what I'm saying? What I'm
Yes,
trying to
ma'am.
say here?
Yes, ma'am.
Yeah, because a first year MBBS will be an absolute disaster in counseling about brain death of the patient. So there should be some experience in handling patient counseling.
Got it, ma'am. We will be
Yeah.
sending you. We will be
Okay.
sending you the drive link by tomorrow afternoon, ma'am, by 1 p.m.
Sure. Okay. Sounds good.
Okay, thank you so much, Jasmeet and
Okay.
Dr. Salau. Very, very
Thank you.
interesting, and I'm sure everybody learned a lot. So over to you, Pujita. I think we can end it now.
Yes, ma'am. Thank you everyone for being here, and thanks once again to each and every speaker who took their time for today's webinar. Thank you so much.
Thank you. See you all tomorrow. Please come at 5 to 5 so we can begin dot at 5.
Yes.
Thank you. Bye-bye.
Thank you, ma'am. Ma'am, can
Thank
we have a
you.
picture?
Yes, of course.
Yeah,
Yeah.
sure.
Jasmeet,
So
please put on
whoever,
your video. And if Dr. Salau can put on her video as well,
Okay.
and everybody else.
guys, whoever can turn on the cameras, do turn on. Yes. This is 3, 2. Okay, wait. I guess everyone is turning on the cameras. Yeah. 3, 2, 1. Yeah. Thank you. Thank you,
Okay.
everyone.
Thank you, everybody.
Thank you.
Right.
Thank you.